Okay. Hi, thank you so much for joining us today. So why don't you introduce yourself to our group, which is Endometriosis Canada, and we're always excited to learn more about doctors that we aren't aware of yet, in case we want to get second or third opinions.
Yeah. Well, actually, first of all, I love in case we want to get second or third opinions, because that's one of the things that I usually tell patients, like number one, when you're selecting your surgeon, you need to make sure that the vibe is there. But if you don't get all your questions answered, get a second or a third or a fourth opinion. But that being said, my name is Dr. José Eugenio, and I am one of the two doctors at the Center for Endometriosis Care in Atlanta, Georgia. Um, and I'm extremely passionate about endo for many, many different reasons. Um, but more importantly, I've dedicated myself to endometriosis almost for the past 10 years, and it's been a very humbling journey. So, right, so it's one of the things that's important to me is the fact that we keep learning and outreaching and working with surgeons from different countries and different portions of the world. Um, and just continue to learn and perfect our craft. Unfortunately, um, there's not a lot of endometriosis surgeons out there, so patients should make sure that they're getting operated by somebody that's truly somebody that's dedicated themselves to only endometriosis, like it's a cancer.
That's why we appreciate you so much, knowing that we don't have a lot of people that take the endo journey that aren't forced into it health-wise.
Mhm.
So having doctors like you that are choosing to help us, it means so much. And I'm sure you're helping so many people. We just want more of you. That's all we could ask for.
Mhm.
So I'll jump into some of the questions. One of the questions a group member put out there was that they have had endometriosis surgery. They're diagnosed with stage 4 endo, and now they want to try to get pregnant. And they're asking if you maybe had any tips on anything they should do.
Okay, so when the first thing is this is the first thing. Um, Endometriosis is highly associated to infertility, right? Even if you have no pain with your periods, you have a 50% chance that if you have infertility, the reason for that infertility is actually associated to endometriosis. That's somebody getting a period while they're at the beach with their friends that did not have like a week of pain before. Somebody that takes like Tylenol or ibuprofen and they're good for the whole cycle. If that person has infertility, she has up to 50% chance of that infertility is actually caused by endometriosis. Now, the factors that cause infertility, how endometriosis causes infertility is very varied, right? So, which is why it's difficult to answer that question because of all the different variables. But if we kind of want to focus on let's just not keep it more than three and let's say that there are different reasons to have infertility with endometriosis. Number one, you can have a problem with sperm getting to where the egg is at the ovary. So that can be broken down into several different categories because you can have a problem because the fallopian tubes are obstructed or blocked, both of them, right? So sperm will never get to where the egg is on top of the ovary, right? You can have a problem because you could have the tubal factor. It could be because one of those fallopian tubes is dilated because it's obstructed. But even though the other one is open, if you have one tube that's destroyed, that tube, because endometriosis is an inflammatory condition, the inflammation that happens in the tube that's blocked, right, can actually leak some of that inflammatory fluid back into the uterus. So that inflammatory fluid is like acid. So imagine that sperm gets inside of there and it's basically landing, sperm that's alkaline, it's landing in the pool of acid, dead. But if you ovulate that beautiful, 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 delicate egg, and it lands in a pool of acid, dead, right? So if you have a blocked fallopian tube producing inflammatory fluid, even if there was sufficient sperm to neutralize the acid, the egg got caught really early and the baby made it back into the uterus. Now, if that other blocked fallopian tube is basically bathing that inner lining of the uterus with that inflammation, right? Because when a tube is obstructed, it's obstructed from the outside, not the portion of the tube that's touching the ovary. No, sorry, that's touching the uterus. So all that fluid that gets accumulated inside of the fallopian tube gets to go back in when the pressure is enough and goes back into where the baby is. So then if you imagine trying to grow a baby in a pool of acid. So that's why you have an increased risk of miscarriages and abortions when you have infertility, when you have endometriosis, right? So another reason to have infertility is because, like, one question that we were talking about before is, or something that you and me talked about off camera, was basically about adenomyosis and endometriosis, right? So around 30% of patients with endometriosis have adenomyosis. I think it's actually even higher than that, but usually the data says 30, 25 to 30%, but I believe it's personally higher. Now, what's the clue? If you have adenomyosis and then you get pregnant, adenomyosis is the condition in which the lining of the uterus, like the wallpaper of the inside portion of the uterus, gets basically full of holes. So a placenta, it basically attaches itself to the inner lining of the uterus. So if the inner lining is flat, the baby and all its blood vessels would basically leach off the mom from the wall. But if the baby gets attached to a portion of the uterus that's full of adenomyosis, the back wall actually is not touching completely the placenta, and you can have holes in different locations where the placenta is, which can cause you to bleed behind the placenta. So if you bleed behind the placenta, you're going to do this. The baby, right, on this side, this is going to happen. It's going to push the placenta away. So that baby may not get sufficient blood supply, which would lead to a missed abortion or a miscarriage or different other things. So that question is hard to answer because there's so many different reasons for infertility, right? And that's without discounting the fact that there's also a male portion of infertility that we need to also keep in mind, because even if you have stage 4 and everything was treated and your tubes are open, then one of the things that happens after surgery is that the fallopian tubes can actually get scarred, and can get scarred in such a way, which is something that I tell my patients. Thank God we do have a really good cohort of patients that we operate with in any stage, and they get pregnant naturally, which is basically what we want. Not that I have anything against IVF treatments, but my goal is for the patient to get pregnant 1, 2, 3, 4, 5 times if she wants to naturally. Because number one, it's free, and you can't beat that. Number two, when a patient has stage 4 bilateral endometriomas and you remove the endometriomas, like if she wants to get pregnant, you can't necessarily be super aggressive with those ovaries. Because if you imagine that you have an endometrioma, right? And then this is the clean ovary and this is the endometrioma. So when you go inside and remove the endometrioma, the inner walls of the uterus are still infected with endometriosis cells. So then when we do a cystectomy, I'm not cutting on the edge, I'm cutting on healthy ovary. So I'm shaving healthy ovary because I want to minimize the risk of recurrence. But when you have a patient with bilateral endometriomas, the risk of recurrence is close to 20 to 30%, which is extremely elevated. So it could be that it could be that inflammation from the cystectomy during surgery can actually decrease the AMH levels for a little bit, but sometimes over time it can go back up to normal levels. And we've seen countless patients that gotten pregnant 6, 7, 8 months after surgery. Right. So that's what we kind of want to do. So, but it's really hard to answer that question without knowing a little bit more details about her case.
There was also another person that had a pregnancy question,
Mhm.
and they said that they were waiting to have an endometriosis surgery, but they were wondering if they should not be trying to have a child because they do want one, or if it would be okay to try while they're waiting for the surgery to see if it happens.
Number two, immediately number two. Like if you have, even if you have, like if you're waiting for, actually, even if you're waiting for surgery, everything's scheduled, your flights are booked, you should still be trying to get pregnant before surgery. Because even though there's an increased risk of miscarriage and abortion is not like 30-40% risk of miscarriage and abortion, right? That is going to increase it. It's increased above baseline, but the actual numbers it's unknown. But I've seen patients that we basically do the mapping, do the MRI, do everything, and schedule them, and the day of surgery they have a positive pregnancy test. There's no better news. Like, well, you got pregnant on your own. Let's put everything on pause. Let's have a successful pregnancy. And after pregnancy, we address the issues that you're having. right? So, which is phenomenal because then we'll give time to everything to cool off, and then 6 months after they deliver, we'll take him back to the operating room and go ahead and do surgery to remove all the disease that's there. Trying to as well preserve their fertility because when you go back in and you have endometriosis, let's say on the fallopian tube, you have to try to shave it. But it also depends on the energy source that your surgeon uses. If they use the robot or if they do laparoscopy with a laser. The laser gives me the capability of basically cutting and shaving layer by layer over the fallopian tube. Why? Because it only cuts at a depth of like 2 millimeters. So the fallopian tubes are very thin. So using conventional robotic techniques, you can actually really quickly slice through the fallopian tube and kill it. So that's kind of the issue. So there may be the possibility that when you do surgery, if the tubes are very destroyed, that there's significant risk of recurrence, then you would remove as much endo as possible, and which can sometimes basically entail actually taking out the fallopian tubes, right? So then that means
Mhm.
that we are now we're now basically obligating the patient to have to go through IVF, which is a double-edged sword, because what makes endometriosis mad? Estrogen. So let's say, and this is an example that I use with a lot of my patients. When you're having a regular menstrual cycle and you're ovulating, you produce one egg, one dominant follicle, or two if you get lucky enough to have twins. But you have one dominant follicle, and let's say that one dominant follicle is producing 10 units of estrogen this month, right? That's the amount of estrogen that's going to stimulate the endometrium inside the uterus and the endometriosis outside of the uterus, right? But if I'm trying to get you pregnant through IVF, I need to harvest on average 3 to 5 eggs per live pregnancy. So I want to give you at least 4 chances, right? So which means that I need to have anywhere between 12 to 20 eggs. So that means that in 1 month, I'm going to make you produce the amount of estrogen that you'd produce in almost over a year and a half of time. Do you understand the concept? So that means that your endo is going to explode, and you cannot understand how many patients we see with poor ovarian reserve. Because on top of the fact that we are stimulating your ovaries are super mega inflamed because they're full of endometriosis. So the quality of the eggs that they extract is significantly less. So, and on top of that, all that stuff is going to make that pelvis stuck like cement. And they are not, and infertility doctors are not going to do the endometriosis surgery. They're not, because they want to basically say, oh, you have a problem. Let's go over the problem and treat the infertility instead of let's try to remove the wall and then figure out how we can get pregnant afterwards. But being a devil's advocate as well, I have to say something. One of the reasons why most infertility doctors just want to go and try to stimulate you to get some eggs, even before surgery, is because they're afraid of something that happens to them very often. They see patients with significant endometriosis. They see patients that have infertility and all these issues. And they make a consultation with their infertility doctors, but then they go back to a general OBGYN that takes them to surgery and says, this ovary is gone, and just cuts the ovary out. So the infertility doctor has nothing to work with. So that they've learned over the years, right, that it's better to stimulate and get at least some eggs and then try to get the patient pregnant. But the problem is that they should be referring not to a general OBGYN that does 3 to 5 endo cases a year. They should be referring to groups like ours that do 500 cases in a year, right? So that's the thing. There's a recent study that came out talking about what a high volume endometriosis surgeon is, and it's laughable what the US considers a high volume endometriosis surgeon, which I think it's like 10 cases a year.
That's high volume.
Because low volume is basically somebody that does, I think, less than 6 cases in a year, right? So if the
Not that
volume is,
much.
and the thing is that 95 or 99% of OBGYNs fall in the low volume case, because I was one. I remember when I was a general OBGYN for 4 years in Rhode Island that I did probably no more than 10 endo cases a year. But I would never, doing 10 endo cases a year, consider myself like a high volume GYN surgeon. That's bananas. But so that basically kind of like shows you how low the bar is for endometriosis surgery. It's 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 like a, I don't know, it's crazy. It's bananas.
It's scary too, and sometimes getting the wrong information and like not knowing that we need someone that specializes in endometriosis and just seeing a regular gynecologist. Like sometimes we're told getting pregnant secure, or you just have to breastfeed longer and breastfeeding secure, and or we get pushed like Lupron a lot. I see that in the group. A lot of people like ask if it's like safe, if they should be trying it, because a lot of people have had bad side effects from it too, that sometimes last longer than the time that they're on the medication. Like sometimes they linger afterwards. Do you have a lot of patients that you see that have Lupron? Because I know it is
Well,
beneficial to some people.
listen. I haven't prescribed. No, no, that's a lie. I think in the last 8 years, I've given Lupron to probably one or maybe two patients, maybe one or two patients in the last 8 years doing exclusively endo surgery.
Wow.
Why? So there are, like, if you start looking, if we do a deep dive on the studies that were utilized to approve Lupron, it's laughable. The protocols and the big pharma companies that used to get Lupron approved and then got the oral forms of Lupron, which I don't want to say any names, approved, piggybacking on the Lupron studies, it's one domino of doo-doo. It's crazy. It's like the side effects that these medications have, and some of them are lifelong, and they're expensive, and they're no better than Depo-Provera. Like they're no better than Depo-Provera. They're no better.
I'm
With
not sure how
significant,
much it is now, but in like 20 years ago, it used to be between 400 and 500 Canadian per injection. I'm not sure what they go for now, but that's how much it was a long time ago.
I know that if you use the oral forms of these some of these medications,
Like
like
Oralisa.
yep, that and and its sisters or buddies or cousins or whatever you want to call it, it could be as high as $1,200 a month, which is literally, somebody that works minimum wage would only work to get their medication if they have no insurance, which is, it's
Yes, so
just,
we have to hope people have insurance, which I know not everyone does.
yeah, not everybody does. Or because it's funny because they say that people with like you have access to healthcare when you have insurance, but some people choose not to access it, right? Because it's not the same. Like you have insurance, but you know that you have a copay of $1,000. Then you have access to healthcare, but you really don't, right? Because you're not gonna be able to copay $1,000 before for a $1,200 medication, right? So it's really sad.
Yeah, even like here, it's not covered. So people would need insurance like through their work or if they purchase their own insurance to be able to cover it. I believe we do have free prescriptions for children, but not for the general public.
Mhm.
You had mentioned hormone replacements before, like estrogen. For patients that have had to have everything removed because of endometriosis and adenomyosis, is that how you say it?
Yeah,
So if they've had like a total hysterectomy and they've had severe endometriosis that was removed and they're put on estrogen afterwards, do you think that would be safe knowing that they have a history of endometriosis, or is it
so
necessary since they don't have a uterus or
so
ovaries?
it depends. Yes, so that's the distinction I want to make. So a total hysterectomy means a partial hysterectomy is the body of the uterus and they leave the cervix. A total hysterectomy is the body of the uterus and they remove the cervix, which is what connects the uterus to the vagina. And they may or may not take out your fallopian tubes. Now, one thing is total hysterectomy or partial hysterectomy, and another thing is cutting out the ovaries. It's a totally different thing. Now, when they have a patient with endometriosis, which we see more often than not, and they're taken to the operating room and they do a total hysterectomy, and on top of that, they add the Sunday night special, meaning they castrate them like dogs. And I use that word on purpose because when you take a woman that is 25, 35 years old, and you castrate her by cutting out her gonads, you put her in surgical menopause. And I use that word on purpose because it's a lot more shocking. Oh, I was castrated. Yes, they cut out your ovaries to put you in surgical menopause. So then how does that, if you're in surgical menopause, how do you go from that? How do you go into giving you medication? Because the ones that you could produce your own estrogen. So why am I going to castrate you to then have you be on hormonal supplementation, right? Even though they say it's a little dosage and they can control it that way, it's extremely important to understand how you need to do these things. So it has to be the absolute exception, not the rule, that women are not castrated for endometriosis. Now, when unfortunately they are, for whatever reason, like they couldn't save the ovary, or she had recurrent pain, or she had pelvic congestion syndrome, or all these vascular syndromes that cause severe varicosities that can actually also increase pelvic pain in a patient with endometriosis. Like you could put them on estrogen. You could, but it depends on many different things. But the most important thing is who did your surgery. Because if you had somebody that went inside and did laparoscopy to try to do a hysterectomy, and they had to call a friend, right? Let me phone a friend. They call a friend, they come in, this looks bad. Let's open the patient. Let's remove the uterus. And now that we're here, let's take out the ovaries. But they left all the other endo behind. If to that patient you give them estrogen, that's when I see the very common in our practice in Atlanta to see women without a uterus, without an ovary, that have a phantom period. They don't have a uterus, so how are they having a period? Because everything was stuck together. So the nodules of endometriosis that were located behind the vagina were left there. And then when they put them on estrogen, that estrogen is sufficient to stimulate those nodules to continue to grow. But where do they grow into? They grow now into the vagina, and they grow back into the intestine. So it's crazy the amount of how many times we see this. Women without a uterus can have a unicorn period every month cyclically on hormonal replacement therapy. So I don't want to demonize the use of estrogen after female castration and hysterectomy for everything. My goal is to make sure that it's not the castration. The issue is who did your surgery and how much disease did they leave behind. Because if they left rectal vaginal nodules, I would not recommend you getting estrogen.
In the case, they probably need another opinion to see if they needed another surgery, right, to finish the job that was left behind. Unfortunately, that happens way too often. We see it in the group of people that have had surgery and they're still in pain afterwards. And sometimes we've like had one person ask, knowing that I'd be speaking with you, that that their doctor said if they're still in pain after, that is probably not related to endometriosis, and they're
No.
wondering, is it
Run.
something else or?
Run, run. Like when I talk to some of my patients, like I usually follow them up. I do a visit with them or telehealth, like 1 or 2 weeks after surgery. If they had a hysterectomy, we do another visit at 6 to 8 weeks after surgery, then 6 months, then after surgery, then on the anniversary of the surgery. Why? Because I want to talk to my patients often enough so that I can figure out what is the thing that's lingering. And we can go into separate questions and separate protocols so that we can actually keep an eye on them to make sure, because endometriosis is a cause of pelvic pain, but it's not the only cause of pelvic pain. But that it is on your physician to rule out the issues that you may be having from endometriosis. And if it's not, after they have been ruled out, is that like, no, it's not that, maybe it's something else. No, what did you do? Did you do a sonogram? Did you do an MRI? Did you send her to go see rheumatology? Did you send them to go see gastroenterology to do motility studies? Did you send them to urology to figure out what's happening to her bladder? Does she have IC? Does she have chronic constipation? Does she have pelvic floor dysfunction? Like you don't know, I mean, how many patients do I see that have had massive surgery and and they may still be in pain, and then with a quick visit to the gastroenterologist, we find out that the patient has dyssynergic defecation. What does this mean? In order for you to defecate, you need to relax your anus so it opens up, and you need to squeeze the rectum, right? So your rectum has to squeeze in order to allow feces to come out naturally. But in patients with chronic pelvic pain, and they may have dyssynergic defecation, they would try to poop, but the anus remains closed. So then the amount of pain that this dyssynergia gives the patient is astronomical, right? And that leads to chronic constipation. So there's so many different things that you have to continue to evaluate. But that only matters if your physician is a true endosurgeon that removed every little corner of endo that he saw on the inside. Because if there's endo that was left on the inside because it was too difficult, then that may be the reason for pain. So you can't move on until you rule out that this patient doesn't have any more endometriosis. Even if it means that she may need a second surgery at 6 months or a year from the first one, right? Because it's easier to treat them early on instead of later. So those are my 2 cents regarding that.
Younger patients, would you recommend waiting till they're out of their teen years to do their first surgery if they have signs of
Absolutely not.
endometriosis?
Absolutely not. Like that is ridiculous in my mind. Like we do like ever since I was in St. Louis, I used to work with a Dr. Powell, which is a phenomenal pediatric gynecologist. And I would say that 100% of the patients that she sent to me had endometriosis. There was one 12-year-old patient that we operated that we did biopsies and they came back negative. But then she came back 2.5 years later. No, she came back 3 years later, still in pain. And then we took her back a second time to see, and the specimens were positive. So we're all like, wait, but it was negative in the beginning, right? So then our conjecture was that like when the teenagers are very, very early, some of those lesions may be negative. But after 16 is my cutoff, like 15 to 16, like I won't take anybody less than 15 to the operating room. Or very, very rarely, unless this patient has a very strong family history of endometriosis. Because most of our endo patients tell us that all this craziness started when they were teenagers and in high school. I mean, in school, they were the best friends. Who's the best friend when they're in endometriosis pain as a teenager? The school nurse. So they were on the first name basis with the school nurses because they saw them so many times, right? So then why do we have to wait for a disease to get horrible? In fact, like when I see patients, teenagers for suspected endometriosis, and we talk to them, we don't do a pelvic exam on a teenager, especially a virginal female. Why would anybody want to do a pelvic exam on a virginal female, right? You would do an abdominal sonogram, not even a transvaginal sonogram, to see what's happening in there. And our rate of finding endo in teenagers was over 95% when we took a patient to the operating room, right? Like including some of the, because we had a lot of patients that Dr. Powell also did not send me that were like, oh, you did surgery on me, and now my daughter is 17 and she has to go back. And that not doing a pelvic exam and not doing a transvaginal sonogram only bit me in the butt one time because I operated on a 18-year-old, on a 17-year-old virginal female that had a rectal nodule. So we did the surgery. She had a large rectal nodule at the age of 17. So we removed everything, and unfortunately, our colorectal was not available that day to come. So I removed everything, left the nodule in place, and came back 3 months later to repeat the surgery, see if anything was left behind, and then just do the bowel resection, and we did a disc. and resected the whole thing. So that's the only time that it's happened to me, that we had to take a teen endo back for a bowel resection. So it's very rare that you see somebody as a teen with a rectal nodule. Very rare.
It's really sad too, especially when they're that young. It's horrible. Same as school, they can't do sports or activities with friends. It affects their whole life mentally and physically. It
Their
can be
self,
really hard.
like what does that do to the life of a teenager when some of her friends are like, oh, they're not going to invite her because she could never come. She's not fun. She's always in pain. She's always complaining about something, but she looks beautiful on the outside, right? So then it becomes a self-fulfilling prophecy. So we invite her, she never comes, so we're not going to invite her because she's not going to come, right? So
Yeah.
what does that do to the psyche of a teenager? That she's going to self-isolate. She's going to have a negative self-image, which leads to increased risk of, we didn't need a study to prove this, but we have one anyway. But if you're a teenager with severe endometriosis, you have increased risk of what? Anxiety, depression, suicidal ideation. Because on top of you have to deal with everything about being a teen, now you have to deal with incapacitating periods, right? It's just a lot. So that's why I think teenagers are the future of focusing on teenagers is the future of the disease. Because don't get me wrong, we love doing those like 6, 7, 8 hour cases. It's super cool. It's super fun because you feel like everything's a mess, and then you're cleaning up everything, and then you're leaving everything like as clean as possible and minimize the scar tissue formation. And seeing the transformation, something horrible to something acceptable and pretty, it's such a like high for me, right? But I would much rather prevent my patients from ever needing a 6, 7 hour surgery, or ever needing to have a combined surgery with me in colorectal, or ever needing to have a combined surgery with me in cardiothoracic surgery because they have horrible neck and shoulder pain. And now we have to come in and cut a chunk of her diaphragm, which will include some of the nerves of the diaphragm, right? Which if she's running and we had to cut endo around the nerve of the diaphragm, she may be out of breath because she may not breathe properly. Right? So all these things can be avoided if we treat teenagers appropriately.
It's actually our campaign that we have and that we're very passionate about is trying to get pamphlets and posters about endometriosis in pediatrician offices and general practitioner offices and in schools for when they're learning about what a healthy period is, so they can learn also what an unhealthy period is and signs to look for, because they don't always learn it at the doctor's office, because we like you've mentioned before, we don't have enough doctors like you who are trained, who know everything about it. So we try to get these pamphlets out so the parents can at least be armed with information, so that if their children are showing signs, they maybe have an idea of what it could be. So that's something that we are really passionate about and trying to get out as many as we can around the country. So we appreciate that you help these children also, and that you're passionate about getting them help and not just like leaving them be, because it can be really hard when people don't believe them sometimes, because like you said, they can look pretty on the outside, and people have an expectation that if you're really sick, you should look a certain way. So then it can be hard for them with that also.
You are 100%
Um,
correct.
I know I've taken up a lot of your time. I don't know if you want to take one more question. That
Yeah,
might be an
go ahead.
easier one.
Go
Um,
ahead.
we've had some people ask about if there's a certain diet that you would recommend, or any types of food that you think could help, because we've heard about anti-inflammatory. Is it low food map, or I don't know if I'm saying
FODMAP.
that correctly. Yes.
People usually say low FODMAP diet. So this is the thing. What I want to have patients do is to work directly with a nutritionist. There's a lot of diets out there. There's a lot of different things. Google can help you. You can go into ChatGPT and they can tell you a diet that's anti-inflammatory. But these diets do not remove the disease. What they do is they take a disease that is highly inflammatory and avoid, or have you avoid, the stuff that you eat that is very inflammatory. because in endo, 2 plus 2 is 20. It's never going to be 4. Anything that you do that's inflammatory, anything that you do that can cause that can alter the course of the disease in a negative way, it's going to potentiate the chronic inflammation. And in fact, one of the things that we pride ourselves is that when we're doing surgery to remove disease, there are specimens that have endo, and there are other specimens that just have chronic inflammation but no endo. Why? Because that means that I removed that the sensitivity of my eye during surgery was so much that I even removed stuff that was inflamed but was negative for endo. So basically, that tells you that I was so aggressive with your disease that some of the specimens were negative, and that they were only inflamed. So anything that looked worse than that is out, truly out, not ablated, truly, truly out, which is why we always give a patient, if they request a video of their surgery, and we give them pictures of their whole surgery and everything so that they can see it. Right? I love it when patients like come back to me in a couple of months and say, "Hey, I was finally able to sit down through that surgery and watch the whole 2, 3, 4, 7 hour thing. That was crazy." I'm like, yeah, because that allows the patient to understand their body. Like when you can see your ovary and us cutting stuff from your ovary or removing the uterus, how the vagina is sutured, you can see us cutting disease that's endo. And then you see what's left after we cut that's all clean. That helps you because, okay, it's no longer there. It doesn't mean that you may not have pain because you can develop scar tissue, but it means that that stuff is no longer there, which helps significantly. Right?
That's
That's my
great. Okay, so nutritionist or dietitian, or are they the same, or you would recommend just nutritionist?
either or, either or, either or.
Okay, fantastic. And we actually know a good one that takes people from all over Canada and sees them virtually as well as in person, where he can at least like check them personally to see if they are low in certain vitamins, things that maybe they don't always get checked when they go for their yearly checkup. So things like that
That's
are great.
ideal. That's ideal. That's ideal. But so it's important to like work with somebody that's like, but also that's going to find alternatives to the stuff that you love. Let's say that you like eating pizza, and then when you do pizza and you put that like really spicy tomato sauce, you're going to have a massive inflammatory reaction. So then what other sauce can we substitute that's not that inflammatory? And gluten and like actually I finally bit the bullet and I did my own uh cauliflower pizza crust. So because patients like, that cauliflower pizza crust sounds disgusting. And I was like, well, it kind of sounds disgusting. But I did it and I looked at a recipe. I mean, I did more of a mess in the kitchen than my wife would have wanted me to. But I did it and it was tasteful. And my daughter and my son ate the thing, right?
Oh,
And
that's great.
they ate it with not being under threat of coercion or anything, or me giving them candy later. They ate it and they liked it. So it's just working with a nutritionist, a dietitian that can help you create a diet that fits for you. Because if you go online and you look at a low FODMAP diet or low acidic diet or anti-inflammatory diets, that may be fine, but you're also going to eat stuff that you may hate. So in order for you to adhere to it, it's better for you to work with them so that you can basically have a map of everything that you eat. One of the things that I tell my patients that's super important is like, how do you know that something is working or not working? Keeping data. And that's what we have to document. So we document a lot, but also I need my patients to document how do they do that? Especially around what they're eating. I tell them, you're going to keep a pain calendar. And let's say that this week, if you get pain, you're going to write everything that you ate the day that you have the pain and the day before. Something so simple. And then they go back over time. And in the last month, they had pain like 9 days. And they checked what they ate on the day that they had the pain and the day before. And they started to notice a pattern. Hey, every time I eat this pizza, like I am in pain for 2, 3 days. So it wasn't everything else that she was eating. It was that she was miserable when she ate that specific pizza. So that's why it's important to work with a nutritionist or a dietitian so that you can figure out alternatives so that you can also eat and be happy.
Yeah, a lot of time we see the list of things we should avoid, and it can be
My God,
intimidating because there's so many things.
I
So when
yeah.
I went vegan about 12 years ago, and so instead of having a list of what not to eat, I had a list of things that I could eat, and I put that on the fridge, and that makes it a lot easier because then you see that you have a wide range of things that you can eat, and you're not looking at the stuff you can't have, so it's not hurting you as much.
Definitely, definitely, definitely.
But we really appreciate your time today. There were like even just putting out a message today that I was going to be speaking with you, there's at least 10 more questions. So maybe we could do a live event if you're up for it with our support group. We are just under 9,000 members, and there's always so many questions that people have that they would love to ask you.
It'll be my pleasure.
Do you
Yeah.
want to maybe share where people can find you, the address, phone number of how, if we want to maybe get a second or third opinion and speak with you, if you do phone appointments also,
Yeah.
because I know not every doctor does.
So we do a lot of telehealth for our patients. We do a lot of free records review in which like we'll they'll send us their information and we'll like peruse over it and give them a quick 15-minute conversation regarding of what we see, where do you think that things are missing or things that are needed, or if they qualify for surgery with us or not qualify for surgery. So I'm currently at the Center for Endometriosis Care, which is centerforendo.com. I'm Dr. Sonervo's partner. And we're in Atlanta, Georgia. We are very open to seeing patients from all over the world. We're very experienced. We've seen a lot of patients from Canada, and we continue to do so. And from different places in the world too. Actually, I think I've talked to a couple of patients from the Dominican Republic that are living in Canada, and then they still come down here and get surgery, which is really an honor for us to see patients that, choose to travel from different countries to come and operate and have surgery with us. But yeah,
Well,
that's it.
we are honored to have you helping us because there's not a lot of doctors. Like we do have maybe a handful in Canada, but because of the wait, people are often leaving either for the UK or Greece, Romania, but most of the time to the US because it is easier. We could even drive down or take a short 1 or 2 hour flight, depending on where it is.
Yeah.
So we love coming to our neighbors to get help, and we appreciate that you guys are there for us.
Great. If you can, if I may introduce a shameless plug, I put a lot of information on Instagram. So anybody wants to follow me is at DR endometriosis, which is like it has a double entendre because it's Dominican Republic endometriosis or Dr. Endometriosis, whichever people want to say it. So
I will make sure to share the link. I've actually been following you and I loved your videos. I think I saw one where you said having an ovary attached maybe to a uterus was
yeah,
like a man
I
having
know.
his
It,
testicles
w-
stuck to his leg.
it wasn't one of my finest moments, but the thing is that I'm so frustrated because like I'm frustrated with the infertility community because if somebody has infertility and we did sonograms, we did stuff and we can't find it, well, operate, do a diagnostic laparoscopy, not diagnostic laparoscopy, go in and remove endo. And if they don't have it, then great, but you checked everything, you saw it, you touched it. But the issue is that to just send somebody with undisclosed infertility or unknown reasons for infertility, that's endo until proven otherwise. So then why stimulate the patient before going inside and if they have it, remove it? Because if they get stimulated, it gets worse. And it's funny because when I tell a woman that, oh, you had a sonogram or what happens a lot? A patient comes in, says, oh, all my sonograms are normal. I'm like, okay, so let me do one. And the sonogram describes ovary as this size by that size by that side on the left, this size like 2 by 3 by 2 on the right. Okay. Do they have a cyst or don't have a cyst? They don't have a cyst. Great. What else can you tell me about the ovary? Well, good blood flow. Okay. What else can you tell me? Is the ovary moving or it's not moving? Right? And there's really easy ways that you can do a transvaginal sonogram ultrasound, and then you can see if the ovary is attached to something. If it's attached to the uterus, or if it's attached to the sidewall. But if I tell the patient, okay, this is your ovary and I'm measuring it, and then I basically, okay, I'm gonna try to move it, and I try to move it, and says that's the pain I get, means that her ovary is stuck, right? And then, oh, this ovary's not moving that well. And she goes like, oh, okay, cool, my ovary's not moving. But if I tell a man, hey, your testicle got caught, or it feels like you got stapled your testicles to your leg, 99% of them cross their legs and do this. Yeah, that's painful, right? And then that's how they usually, husbands can understand or partners can understand the amount of pain that is to walk around with both of your ovaries stuck to your pelvic wall, right? So that's why, and it's sad that that 99% of sonographers don't evaluate ovarian movement. If it's stuck, if it's not stuck, or what is it, right? And it's something so simple to do. And that's for the importance. That's why patients need to have endometriosis mapping. Same with all the MRI studies that we see and we get, which are so substandard. And they do it one time and another year, and everything's negative. And then we do it in the same study with a slightly different protocol with rectal preparation and rectal enema and vaginal gel. And then we find a massive nodule that was there for years, but all the CT scans were normal, right? So it's just so frustrating. So
And the
some,
ultrasounds don't show it, right? Like the normal ultrasounds, we hear so often that people with endo have the ultrasounds and everything looks normal. So like they're just left because the ultrasound was fine, but then
yeah,
they still struggle in pain. And when they have surgery, it's found out that they do have endo.
yeah, because they don't have an ultrasound by an expert. Like an expert should be able to do an ultrasound, make sure that like look at your ureters, making sure that like your ureters are going. I had a case that I was in a patient that came in from Ecuador recently for an evaluation. Um, and when I'm doing her study, so she did a free records review, then she did a consultation. We put the study, she came over to get everything evaluated before surgery. And when I do her sonogram, I'm like, hey, this ureter is not moving. Like there's no flow of urine from this ureter. Her kidney was already dead, right? So it's like you
It's like
can
silent
tell
loss, right?
it's a silent loss of the kidney, right? But her sonograms just showed that she had ovarian cyst. So it depends on who does your MRI. It depends on who does your ultrasound. Like that's the most important thing.
So we have like our true endosurgeons that tell their patients that even if they have to travel to come to their hospital to have the test done because they want to make sure it's with their technicians. Like we have Dr. Leonardi at McMaster who is always training. How do you pronounce? Is it Sonic? I don't know how to say it. Sorry, the name of the technicians that do the ultrasounds.
So sonographers.
Yes, he's
So
always training them. I don't know if you've heard of Dr. Leonardi. He travels a lot. He's recently in Australia. I believe he was educated from Australia, but then he's Canadian and he came back to work here and he works with Dr. Leonardi. So he works with Dr. Leyland at McMaster in Hamilton. And they are two of the best that we have here in Canada, but
Matthew
they
Lenardi?
often, yes,
Mm,
yes.
okay.
But they sometimes close their clinic because they have so many referrals. They might get like 1,000 per week and they can't keep up with everyone. Or they'll only take people sometimes within their town or the area that they're in because it's just too many patients that want to see them.
Yeah. No, I mean it can be daunting the amount of studies that could get. I mean, I'll look into him, but I know that like radiologists and sonographers that dedicate themselves to this look like can tell me basically, you know, the 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 best classification for endometriosis, which is basically you go in, you have the NCN classification, and then you have an NCN number of both uterosacrals, tubes, ovaries, rectovaginal septum, cervix, mobility, everything, nodules, like, so it's a much cleaner map of endo. And then when I have patients, for example, that come up from Dominican Republic, I have them get an endometriosis mapping before they come to the US because my team that sees them in Dominican Republic like have all gotten extensive training in endometriosis mapping in Brazil and different locations. And they're phenomenal. And literally it's like operating with a roadmap. So I operate and I put their report there. And as I'm doing surgery, okay, what did they say about this? How big is this? And I go and I check and I take a picture before and after. Because I have that feedback with them. Imagine that, let's say that Dr. Leonardi was my radiologist. Is he a radiologist? I don't know his specialty. But I'm so
I believe he is also, yes. And he also works at the Sugo Clinic, which is possibly maybe the only one in Canada that has endo mapping available. There possibly might be in BC, but I know for a long time we didn't have it anywhere in Canada until they got it here in Hamilton, which is just like the west part of Toronto.
okay. But so
It can be
imagine
hard to get mapping done though, because there's not a lot of places that have it.
that. And it takes a lot of time. Like that's the thing. Because for example, when I send my patients to the Dominican Republic to get a mapping, they'll basically they'll do the whole bowel prep, like they're gonna get a colonoscopy so their colon is completely clean. They'll get an enema like 30 minutes to an hour before they do the transvaginal sonogram. And then they go in and do the MRI immediately. So they go from one room, sonogram mapping everything, ovaries, liver, kidneys, diaphragm, spleen, and I want to see the whole anterior abdominal wall. And the radiologist would scan the left abdominal wall, right abdominal wall, the rectus muscle, C-section scar, because we're actively looking in all the locations where endo is most common. So that when we take a patient to the operating room, I didn't miss that she had a 1.5 centimeter nodule on the left of her belly button that was very tiny. And because if I'm operating on her, I want to maximize that surgery and remove endo from anywhere I see. Right? So operating with looking at the endo map, it's phenomenal because you may forget something, but you just go line by line. Okay, spleen, clean, liver, diaphragm, nodule here. Okay, let's go. Look for it, take a picture, cut it out, suture the diaphragm, and then move forward, right? So it's very systematic.
Okay, well, it's really informative. You've helped us so much. I will make sure to include a link to your Instagram, to your website. Is there anywhere else that we could follow you? Are you on X or you're on Facebook, correct?
Yeah, we have a page on Facebook where we patients reach out to. I'm on TikTok, but I don't know about that yet. So it's just too many social media stuff for me. Like it's just sometimes becomes a little bit overwhelming because we have so many questions, which we're really happy to get. Uh, but sometimes it's hard to keep up with who sent me a message on Instagram, who sent me a message on on Facebook, and then now also who sent me a message on TikTok or whatever. It's just maybe a little too much, but I'll get there.
Well, our live event will be helpful since it will have like one area where many people can come and ask you questions also.
Awesome. Let me know. We'll have some fun.
Thank you. And we'll make it easy for people to find you in case they want to find you with the links, as I said. And we really appreciate you taking the time. And we look forward to doing a live event too.
Awesome. I'll talk to you soon.
Thank you. Have a good night.
Bye bye.